Good afternoon. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network. Thank you so much for being here today, September 18th, 2019, for our North Carolina Community College System Lecture Series. This is our Oncology Lecture Series from the UNC Cancer Network and the Lineberger Comprehensive Cancer Center. We really appreciate your being here today. And let me just go through a few things and then we'll meet our guest and get started. Let's see, what can I tell you? From here, I should just mention that we have a website, unccn.org. You can go there and find out all sorts of information about past lectures, future lectures, etc. We have a learning portal, and that's where you go if you want to get credit for lectures, including for our community college series. We've got certificates of participation. So if you're not receiving that for the live lecture, but if you're watching this later as a recorded lecture, you can go to learn.unccn.org and find out more information. And of course, everything is free. We're on Facebook. Please like us there. You can find us on Twitter. You can find us on LinkedIn. Lots of places to find out more about us. We'll be using Poll Everywhere today. This is completely anonymous. Really hope that you'll use this today. This is a great way to interact with our presenter and then to ask questions at the end. All anonymous. Please use this. Two ways you can go about this. Easiest way, I think, is to go to pollev.com/UNCCN. So on any smartphone, tablet, laptop, you name it, that has a browser, you just go to pollev, pollev.com/UNCCN, and then you'll see the questions as the questions come up here in the studio, and then at the end you'll have an opportunity to type in your questions, and we hope that you'll do that. If you prefer to use a phone with texting capabilities, you can just go ahead and in the to field type in 22333. In the message field, UNCCN, you'll get a little message back that says join, and then you can type in the letter that corresponds with the answer that you think is right, and then text your questions through that at the end. So feel free to do that as well. We are asking, please fill out a survey associated with this. This helps us know how we're doing, and we really value these surveys. So at the end of this lecture, please go to unccn.org/eval, and take care of that survey for us. Thank you again ahead of time for doing that. All right. We'll be using, as I mentioned, Poll Everywhere, and here's our first question, and this is just a preview, and then we'll actually go to the Poll Everywhere screen in a minute. But which of the following statements about radiation oncology is true? And so you're going to pick A, B, C, or D, whichever one you think is right. A, radiation therapy is never combined with surgery or chemotherapy. B, radiation therapy may be combined with surgery and or chemotherapy depending on the treatment plan. C, radiation therapy is always performed with chemotherapy. Or D, radiation therapy is always performed with surgery. So take a look at all of those, and then we'll pop that up in a minute. And without further ado, let me switch our cameras around here so that you get a view. And I want to welcome our presenter, Dr. Ashley Weiner. Thank you so much for being here today.
It's a pleasure to be here.
All right, so let's see, what do we know about you? Let's see if we get this right. A radiation oncologist at UNC Hospital in Chapel Hill.
Correct.
And clinical focuses on thoracic malignancies, primarily lung cancer, and gynecologic malignancies, primarily endometrial and cervical cancer. A bachelor's degree from Duke University, and then a PhD from Vanderbilt University, both in biomedical engineering. Received an MD from Vanderbilt University, School of Medicine. Residency training in radiation oncology at Washington University in St. Louis. So you've been all over.
I have, yeah.
That's great. At UNC director of the residency program in radiation oncology, as well as the course director of the medical student clerkship. And research focuses on biomarkers for treatment response and mitigation of toxicities during chemoradiotherapy for cervical cancer and optimizing radiotherapy in terms of treatment efficacy and toxicity for early stage lung cancer.
That sounds right.
That is great. But can you tell me a little bit about your trajectory? I was stumbled with that word trajectory from and when you became interested in oncology.
That's actually an interesting question because you can almost get through all of medical school without even hearing about radiation oncology.
Okay.
It's a very small, very, very specialized field. So I knew I was interested in oncology. I knew I was interested in cancer, which is not one disease, but really hundreds and hundreds of different diseases in which the cells are just growing crazy and not doing what they're supposed to do. So I was interested in the biology as well as the treatment. And then I have an engineering background, and radiation oncology is really all about cool toys.
Yeah.
So kind of all the different treatment machines and treatment modalities we have within radiation oncology were very interesting to me.
Great. Thank you. And what's one thing we should know maybe outside of your professional bio about you?
I guess the most interesting thing that I do outside of work is I take Taekwondo with my 8-year-old daughter, and I'll be testing for my black belt up here in December pretty soon. So we're very excited about that.
Well, we'll wish you the best with that. That is exciting. Thank you. So without further ado, let's get to it. First, we'll get to our poll everywhere question. So again, which of the following statement about radiation oncology is true? And you can go to pollev.com/UNCCN. And if you think it's A, radiation therapy is never combined with surgery or chemotherapy, select that one. B, radiation therapy may be combined with surgery and or chemotherapy depending on the treatment plan. C, radiation therapy is always performed with chemotherapy, or radiation therapy is always performed with surgery. I see a trend going on
I
here.
definitely see a trend. I mean, I don't know if I need to do my talk.
They have it. You're good. No, stay for. I guarantee you're going to learn some
good stuff
new
here.
things. So, all right. So that is correct. So may be combined with one of those. All right. And without further ado, introduction to radiation oncology with Dr. Ashley Weiner. And there's the keyboard and the mouse.
Thank you so
can
much.
Take it away.
All
Thank you.
Let's see. So I've got a couple of goals and objectives for this talk here today. I really want you to be able to understand the logistics of radiation treatments, understand how radiation works. I want to discuss how we combine several different treatments together for patients with cancer. And also, there's several different types of radiation, and I want to be able to really discuss the different types so you have an idea of what patients go through when they're going through these treatments. In terms of my outline, I'm going to start briefly with a little bit about what cancer is and its impact on us in the United States as well as in the world, the different ways that we treat cancer, and then I want to dive a little bit into what is a radiation treatment. I really want to give a lot of detail with a case example where I'm going to walk you through the initial consultation and treatment planning of a patient that I saw with stage 3 lung cancer. And then I also want to go through a couple of different examples of radiation treatment plans and the things that we think about when we're delivering radiation to a patient with cancer. So what is cancer? It's easy to think of cancer as just one disease, but really each type of cancer can be a vastly different disease. All of them are characterized by uncontrolled abnormal growth of cells. So the cells here in this picture, they have DNA, and you can see the normal cells, which have their DNA here, and then cancer cells also have DNA, but they have these mutations. These mutations, I call it making the cancer cell dumb in a way. They don't perform their normal function, but they make it so that they can grow and divide in an uncontrolled fashion. So this is obviously not a good thing because the local growth can cause a problem, or it can cause problems if the cancer cells go elsewhere in the body, which is called metastasis. So just to give some numbers of the impact of cancer within the world, in 2018 there were 17 million new cancer diagnoses and 9.5 million deaths, and this is increasing as our population is aging. More than half of all cancer patients are thought to receive radiation treatments at some point in their cancer course, whether that's initially or sometime later in the course of disease. Just to kind of compare, this is now within the United States, but different causes of death. Heart disease is still up here at number 1. These are 2017 statistics. But then cancer doesn't fall that far behind with about 600,000 deaths annually. And this is significantly higher than those dying of accidents or of lung disease. This chart is a little bit busy, but it breaks down the estimated number of new cases of cancer and deaths of cancer, dividing it amongst both men and female patients. So you can see the incidence of prostate cancer in men is the greatest, breast cancer in women, And these are followed by lung, bronchus, or colorectal cancer in both patients. And then there's a little bit of differences in the two genders, with endometrial cancer being fourth for women, bladder cancer being fourth for men. And you can see the order changes a little bit when we look at deaths, where we see more men dying of lung cancer than prostate cancer, and more women dying of lung cancer and breast cancer. And this tells you again a little bit about how all these cancers are truly different diseases, that we have to think about each type of cancer in a different fashion to determine the treatment course. As a radiation doctor, I treat a lot of different types of cancer with radiation, and most of these that you've seen on our list. So gastrointestinal, these are the stomach, the colorectal cancers, liver cancers. Gynecologic can include cervical cancer, ovarian, or endometrial. Thoracic would be typically a lung cancer. Lymphomas and leukemias are cancers of the blood organs. Genitourinary would be prostate or bladder. Sarcomas are soft tissue tumors, often found sort of in the back of the abdomen, or more commonly in the arm or the leg. Head and neck cancers, cancers of the brain, the central nervous system, or the spinal cord. And then I list pediatric cancers here, which really isn't a type of cancer, but it's something that we sort of think about a little bit differently, because there's a whole host of different types of cancers that can occur in children that involve all of these disease sites. And we think very carefully when using radiation in a child because of risks of long-term complications. So now we've talked a little bit about what cancer is and how it's really a host of different diseases. I want to go a little bit into the different treatment options that we have for cancer and how we think about how to select the different types for each type of cancer. We mentioned how cancer can be a local problem. It can be a tumor growing uncontrolled somewhere in the body, but it can also be a systemic problem, whether that's the risk of cells circulating and finding a spot to grow in other organs, or whether that's the case of leukemia, where the cancer is actually in the bloodstream. We divide treatments similarly into local and systemic therapies. So local therapies are what we think about with surgery, which everyone is familiar with, where a tumor is removed during an operation, or radiation, which is typically focused X-ray treatment, again, targeting mainly a tumor. We also have systemic therapies, which historically everyone thought of this as predominantly chemotherapy, but now there have been significant advances in that field, and so there are things such as hormonal therapy that can block the hormone receptors that might drive a prostate cancer, that might drive a breast cancer, that might drive an endometrial cancer. There are targeted therapies that could target specific mutations that might be found in, say, a melanoma or a lung cancer, or immunotherapy, which is a very new hot topic in which we have medications that actually enable the body's immune system to better fight off a cancer. So these treatments can all be used individually, or more often they're used in some combination to optimally treat cancer. This is sort of a kind of similar overview of the care in oncology, but instead of based on the types of treatment, based on the different modalities. So kind of at the top of this pyramid here, we have our medical oncologist, and this is what most people think of when they think of a cancer doctor. These could be either adult oncologists who have trained in internal medicine, or pediatric oncologists who are trained in pediatrics and then treat children with cancer. So a medical oncologist is going to give chemotherapy, they're going to give targeted agents, they're going to give immunotherapy. But we also have our surgical oncologist, which is not just one specialty, but can involve neurosurgeons, thoracic surgeons, colorectal surgeons, gynecologic surgeons, orthopedic surgeons for bones, a urologist who might do a surgery on a prostate, eye surgeons, the ophthalmologist, or skin surgeons, the dermatologist. So a whole lot of different specialists of surgeons, depending on the type of tumor. And then we have radiation oncologists, which I'm a radiation oncologist, and of course I'll talk more about this today, who we are trained to treat all of the different cancer types. Some cancers are more likely to lend themselves to radiation than others, and we'll talk about how we think about that process. If we think about a tumor in someone's body, when going to a surgery, there is a tumor that a patient can see. So imagine that this tumor is in someone's leg. So you can feel the mass, you can go in for surgery, you can see the mass and remove the mass. But we also know that there's microscopic extent of disease. So this is disease that you can't see with the eye, but you could see under a microscope. So we know that all tumors are always a little bit larger under the microscope than they're going to appear with the eye. This is just something that's important to consider when we're designing a local treatment, particularly a surgery, where you want to have a very wide margin to get all these microscopic extensions. However, you don't want to do such a large surgery that you have a huge impact on the patient's life. We talked a little bit about the cancer's ability to spread. So this ability to spread can make a systemic therapy or a therapy that's through a pill or through an IV more important. Here's an example of a melanoma, which started on a patient's arm and then spread to the liver, to the brain, and to the lymph nodes under the arm. And you can imagine here that a local treatment targeted at just this one spot in the arm is clearly not going to impact the disease in the liver, the brain, or the lymph nodes under the arm. And this is again a picture of a gross specimen of a liver that is removed with metastatic disease, an example of how this normal liver tissue, which is in this dark red, has been replaced by these tumors from a pancreatic cancer. So you can see here that these are situations that a local therapy such as radiation or surgery really wouldn't have impact in this systemic disease. So how do we think about the different types of cancer and picking the treatments? So this is a sort of busy slide here, but if you think about a cancer in terms of risk of systemic disease, which means risk of cancer going outside of where it started, or we talk about risk of how much it's going to extend locally, so extend within its site. So down here, in a skin cancer and an early stage larynx cancer, these are really only local diseases. There's not a high risk of the cancer moving elsewhere in the body. And at the same time, typically they don't extend that far beyond their site. So these are things, for example, that are very easily treated with a local therapy. In contrast, if we have a tumor that's a leukemia, or a cancer that's a leukemia that is a blood-borne cancer, or a cancer that we know has already spread from its initial site, for example, a lung cancer that's gone to the brain or to the liver, we know that there is already a significant burden of systemic disease. And that increases the importance of a systemic therapy, such as a chemotherapy, an immunotherapy, or a targeted agent. We also have diseases such as a low-grade sarcoma, which is a soft tissue tumor, or a brain tumor, which is a really high risk of local spread, but not as high of a risk of spreading somewhere else in the body. And these are ones that might need more than one local treatment. For example, a surgery and radiation to really control the tumor. Whereas a chemotherapy wouldn't be used as much to prevent spread of disease, but maybe more to help control the local disease. Then finally, we have a lot of different tumors following this gray circle here. And so these are all cancers that are mostly a local problem, such as within the breast, within the rectum, within the prostate, within the lung, or the pancreas, that have either a moderate risk of spreading to other organs or actually a very high risk of spreading to other organs. So these are all ones that we have a careful balance in an initial diagnosis that's just localized to that one site. There still is an importance of systemic therapy to really prevent spread to other organs within the body. So it's always important when we see a patient with a new cancer diagnosis to really classify it into something that's more of a local problem, more of a systemic problem throughout the body, and really tailor the therapies based on those factors. So I mentioned that radiation is a local treatment. Using radiation doesn't always mean that we're treating to try to cure a cancer. Sometimes we do radiation with palliative intent, which means we're trying to help a symptom. Radiation can be used to a cancer that's gone to the bone to help with pain in the bone. It can be used if there is a bleeding skin tumor to help the bleeding. And it can be used in the situation if the tumor has gone to the brain or to the spinal cord and really help a neurologic symptom, which might be trouble speaking, weakness in an arm or leg, numbness, inability to walk. These are palliative treatments, again, to really help with the symptom and improve a patient's quality of life. The other treatments that I have listed here are all more types of curative intent treatment. So a patient could be treated with what we call definitive radiation, which means curative intent without doing a surgery. It could be neoadjuvant radiation with the goal of shrinking a tumor so that a surgery can be performed. Or it could be adjuvant radiation therapy, which means a surgery has been performed, but there's some intermediate risk of the cancer recurring within the surgical site, and we would administer radiation following that. And then it's important to consider that chemotherapy or other systemic therapies can play a role in any of these types. It can play a role in the palliative situation, the definitive situation to boost the efficacy of radiation, and then it can also be used in the neoadjuvant or adjuvant setting. When a patient is a candidate for a local therapy due to a localized cancer diagnosis, we have to carefully think about whether we're going to use surgery, radiation, or both. I mentioned the adjuvant radiation and neoadjuvant radiation on the previous slide. One thing I didn't mention was that radiation can sometimes allow a smaller surgery to be performed. An example is breast cancer, where we know that outcomes following a mastectomy or removal of the whole breast is the same as a partial mastectomy with radiation delivered afterwards. So many patients are going to prefer a partial mastectomy for better cosmetic impact and then have radiation and have equally equivalent cancer control and survival. Another example of this is an extremity sarcoma, in which we know that doing a wide local excision with radiation either before or afterwards can have the same outcomes in terms of cancer control as an amputation of an arm or limb, which is obviously of benefit for a patient in terms of their quality of life. These other examples I have here of adjuvant radiation, such as lung, head and neck, prostate, or brain, we might have risk factors for recurrence that we would want to do radiation afterwards. Or rectal cancer is an example where we often do a radiation course prior to surgery to improve the outcomes and the risk of cancer returning after surgery. There are also occasions where radiation treatment is used alone instead of a surgical operation. That could be either an early radiation or an early head and neck cancer, where the surgical option would be removal of the entire voice box, or the radiation option would allow sparing of the voice box and the ability to continue with speech. Or an advanced head and neck cancer, where the surgery might be terribly disfiguring, and we can often treat with radiation and chemotherapy alone with cure rates. Advanced cervical cancer would be a tumor that might not be amenable to a surgery and treated with radiation. And then some patients are just too ill for a surgery, and we treat them with radiation because there would be a less chance of toxicities. And it's always a careful risk-benefit assessment. Some cancers, we know that the outcomes are similar between radiation and surgery, and that might be something that sways towards the treatment with the modality that has the least number of side effects. Just briefly, the role of chemotherapy is kind of twofold. Sometimes chemotherapy is used as a boost to make the radiation more effective, and sometimes the systemic impact is more important. Also, there's the emerging role of immunotherapy and targeted therapies, which is going to be beyond the scope of this talk. And now we're going to have our next question. So, which of the following statements is true about how we treat cancer with radiation and its impact? A is radiation cannot be used for palliative care. B is radiation is only used for breast cancer. C, radiation therapy can be used before, during, or after forms of therapy, or on its own without other forms of therapy. Or D, patients who aren't candidates for surgery also are not candidates for radiation therapy.
All right, so take a few more seconds to go ahead and look this over and put in your answer. Again, all of these are anonymous, so even if you're not sure, go ahead and take a risk and put in what you feel is the best choice. How are they doing, Dr. Weiner?
I think they're really understanding things.
Good, good.
Now I'll have to talk a little bit more about what radiation is.
Great.
So what is radiation? I've talked a little bit about kind of when we would use radiation, but I've told you nothing about what a radiation treatment is. And often for patients coming into our clinic, this is sort of a black box, and they have no clue what to expect. So radiation or X-ray treatments, that's one of the first things I tell my patients when they come to the treatment. X-rays were discovered back in the late 1800s, and they were actually used to treat a mole on someone, to make a hairy mole go away 2 years after the invention. And even, 20 years, 25 years after that, it was used to cure a cancer of the larynx. So X-rays are man-made rays, which are targeting here, similar to use for X-rays or CT scans that we have. In addition, we have radioactive isotopes, which were also discovered in the late 1800s. Radioactive isotopes are naturally or man-made things that deliver not X-rays, but alpha, beta, and gamma rays. Again, naturally occurring by nuclear decay, but these can also generate radiation which can be used for treatments. Both are ionizing radiation. The treatments are photon treatments, so they're a wave. The X-rays are people-made, and then an electron strikes a target. The gamma rays are by nuclear decay, which can be naturally occurring from elements. How does radiation kill cancer cells? Everyone comes in my clinic and thinks that I'm going to burn the cancer away. Well, radiation kills cancer cells by DNA damage. I mentioned how the cells had DNA, and the cancer cells have mutations that let them grow without any checkpoints, grow and spread. They also are not terribly intelligent cells, and they're not good at repairing the damaged DNA that is done with radiation. So when a patient gets a radiation treatment, the cancer cells have this DNA damage. They're not insta-killed, but they eventually die off because they're unable to repair the damage. In contrast, the body's normal cells are able to repair this damage to some extent and continue doing their normal functions. You might hear of a patient coming in and getting radiation treatment and getting many fractions of radiation. Fractionation means giving lots of small radiation doses over the course of many days instead of one large dose. We know that a rapidly growing tissue in the body, such as a tumor or the lining of the mouth, the mucosa, or the skin, is not really impacted in terms of efficacy of killing a tumor or side effects by giving this small dose a day. So we don't impact the ability to cure cancer by giving the small dose a day. But we do know that slowly growing tissues in the body, such as the lung, the brain, the nerves, the blood vessels, they actually have much fewer side effects with fractionation. So that's not, you might be hearing of a patient coming in for 3 to 6 weeks of radiation. It's really not to have more impact for the tumor, it's to be safer for the normal tissues. The radiation dose is called gray. So you may hear of a patient getting 60 gray of radiation as a fairly standard dose, but there's a huge variety in radiation doses depending on the treatment site or the type of tumor. Typically, radiation is delivered 5 days a week, Monday through Friday, for courses of up to 7 weeks. And our typical radiation dose is about 1.8 to 2 gray per day, although there are many exceptions. This image here is a linear accelerator, which is our standard radiation treatment machine. So you can see here, there is this couch that the patient will lie on while they're getting a radiation treatment. And then the X-rays come from this radiation treatment head, and they're shielding within the machine, and then further shielding to actually deliver a customized beam of radiation for each patient. The room is very well shielded so that there's no radiation exposure to personnel. And there are also different imaging devices, both on the ceiling and within the X-ray machine. And this, in addition to delivering radiation treatment, these X-rays can be used to image the patient on the table to ensure that they're lined up to receive the radiation treatment. So radiation therapists are the ones that operate the radiation machine, and these are typically X-ray technicians who have extra training for radiation therapy, and so they're trained in setting up the patient, operating the machine, lining up the images, and delivering the treatment. And that's a very critical part of radiation therapy. There are also more specialized machines, such as the CyberKnife, in which the treatment head contains the linear accelerator, and it can move around at many, many different angles to focus in on a tumor. So again, on a robotic head. There's also a gamma knife, which doesn't create X-rays, but it has cobalt sources. So this uses a radioisotope. So this is always have some degree of radioactivity, but there's shielding within the machine. This is used only for brain treatment. So you can see a patient lying here with a frame on his head to make sure that they hold still for delivery of a single dose, high dose of radiation, which is in contrast to the small doses over many different days. So that's one way we can do radiation in a different fashion, by using extra precision with imaging and immobilization with this frame. We can deliver a high dose in a single fraction instead of bringing a patient in for 6 weeks of treatment. While these radiation treatments where patients lying on a table and receiving some type of X-ray or photon therapy is what's typically thought of with the radiation treatment, I did also want to mention there are some procedure-based radiation techniques. These can involve implanted seeds that remain in place indefinitely and the radiation decays over time. It can also involve temporary catheters that are removed after the radiation treatment is delivered. And I do want to give a couple of images for both prostate treatments and cervix treatments so you can have kind of an idea of what is involved in these implants. First here are a series of images for a radiation implant for a cervical cancer. For a cervical cancer that's over a certain size, we treat with radiation and chemotherapy alone. This is a cartoon drawing of a woman's uterus up here. This is the cervix here, which has a tumor in it. And then this would be the vagina below. And then you can see this implant is called a tandem and ovoid. So this tandem goes through the os, which is the hole in the cervix, up into the uterus, and you can have radiation sources within that. And then also these are ovoids, which are placed right up at the top of the vagina against the cervix. And this, as you can imagine, this is just an example of a radiation dose distribution. The highest dose here is right in the area where you would envision the tumor being. We can image the implant using x-rays. And so this is an AP film from the front, and this is a lateral view from the side, so you can visualize the implant. And you can also visualize this using a CT scan or an MRI. And this is just an example of what these devices look like. So you can see this long, thin piece, which is this tandem that goes up into the uterus, and the ovoids, which go up into the vagina, and there's different sizes. So the radiation oncologist would place this implant in the clinic in a procedure room, do imaging, and calculate a radiation plan. And then radiation sources would feed through these catheters and sit for desired periods of time to deliver this radiation dose. This would all be removed before the patient is discharged from the clinic. In contrast, here's an example of a prostate seed implant. So this is a patient lying on the table. This is the prostate here. So here's the man's bladder and prostate. And this is an ultrasound which goes into the rectum to be able to visualize the prostate. This is a picture of the prostate as seen on the ultrasound. And these are needles which are placed through a grid directly into the prostate. And each deposited a set of seeds, which can be seen here on an x-ray. This is a customized, it looks like a random distribution, but it's actually a customized distribution based on placement of the catheters to deliver a dose of radiation to the prostate. These seeds stay in place. The prostate is not removed with surgery, but this is a curative treatment of prostate cancer. And because of the type of radiation particles that's used, it's actually very minimal, if any, radiation exposure to any family members over time. And eventually these will have no radioactivity. So those are just an example of radiation that can be delivered with catheters, which are removed in clinic, or seeds, which stay in place and deliver radiation slowly over time. Another example of a more specialized radiation technique is intraoperative radiation, where we could have a situation that a surgeon is worried that they're going to have a little bit of a tumor left behind after their surgery that they're not able to remove. This is a device that can be moved around over the surgical opening to deliver radiation directly to an area that's at risk during the surgery. And then the patient is then allowed to recover from the surgery and then go home with normal healing and no really impact on the surgery other than increasing the time in the operating room by a little bit. All right, we have another poll here. Which one of the following is true about what radiation is and how it's used? X-rays and gamma rays are both naturally occurring forms of photons. B, cancer cells are very good at repairing DNA damage. C, radiation is measured in the units gray. And brachytherapy uses radiation seeds and catheters that are implanted permanently.
All right, and again, if you'll take just a few more seconds to put in what you feel is the best answer. Dr. Weiner, how are they doing this time?
Doing great.
Good.
Very happy.
All right, thanks again to all of you who are participating in the poll.
All right. What I wanted to do next was to walk through a case example of what a patient, the things I think about when I see a patient with a new cancer diagnosis and the steps that they go through in receiving a radiation treatment. This is an example of a timeline. So I see a patient for consultation, which is a meeting in my clinic, just similar to as it would be when you see your primary care doctor. At that time, I decide what their plan of attack is going to be in terms of treatment of their cancer, and I often have to talk with many other providers to coordinate their care. So it could be immediately that they're going to proceed with radiation, or it could be many months, or it could be never. Once we've decided to proceed with radiation treatments, the patient will undergo a simulation, which is a CT scan to plan the radiation treatment. And then I will work on making a treatment plan, which I'm going to go through the details of that in just a little bit. Then they'll start their radiation treatments, and I'll see them in my clinic office once a week during the treatment. I don't see them the days of their actual radiation treatments. Again, the radiation therapists are the ones who operate the treatment machines and see the patients on a daily basis. But then I follow up with the patients in my clinic for many years. For one reason is to look for any signs of cancer recurrence, and another reason is to look for any possible side effects of radiation that may occur so that I could help with any treatments for side effects if needed. So my example of a case is a 57-year-old female that I saw in my clinic who had initially presented to her primary care doctor. She was complaining of some cough and shortness of breath that had been ongoing for about 6 weeks. She didn't have any fevers. She didn't feel like she had a pneumonia, but this was just very concerning for her. She also lost a decent amount of weight over the past few months. She had lost 25 pounds, and she had not been trying to diet. She was a current smoker, smoking 2 packs per day for 30 years. In clinic, her primary care doctor listened to her lungs and noticed that they couldn't really hear sounds of her breathing in the upper lobe of her right lung. So they rightfully referred her to get a chest x-ray, which looked like it showed a mass in the right upper lobe of the lung. And this was concerning for lung cancer. We need a lot more information than that before we can treat a cancer. First of all, we would need a biopsy, which actually gives the cancer diagnosis. This would be a piece of tissue. And we also need to stage the cancer. We need to see how large is the tumor, where is it located, and has it spread to lymph nodes, or has it spread to other organs in the body? And really both of these are needed to develop the full treatment plan. The biopsy can be performed in a few different ways. It can be used with guidance of a CT scan or by bronchoscopy, which is a scope which goes through the airway to reach the tumor. The patient who's suspected to have an advanced lung cancer needs a PET scan, which is a part of CT scan and part a scan that uses a dye that allows any cells that use a lot of glucose or sugar to light up. So for example, your brain, your heart would light up because they use a lot of sugar as they're working, but also cancer cells will light up. And also, we know that lung cancer has a very high likelihood of going to the brain, so the patient would need a brain MRI to further evaluate because that's not seen very well in the PET CT scan. For this patient, they did have a biopsy, and it showed a non-small cell lung cancer, an adenocarcinoma, and all of the imaging showed that she had the right upper lobe mass. She had some lymph nodes involved in the middle of her chest. There was no disease outside of the chest, including the brain, and so this is a stage 3 lung cancer. This patient would be evaluated by a surgeon, a medical oncologist, and myself, a radiation oncologist. And in this case, she had many lymph nodes involved in the middle of her chest, so the surgeon thought she would not be a good candidate for surgery. And so her treatment was decided to be 30 radiation treatments with chemo delivered once a week during the course of radiation, and then she would receive immunotherapy following, which is a standard of care treatment for a stage 3 lung cancer. So when I see a patient in clinic, I go through all of their history related to the cancer diagnosis. But I always have to think not just about the tumor, but about all the patient's other medical problems and their performance status, which is how they're doing on a day-to-day basis. What are they able to do around the house? Are they up and out of bed? Because that's going to determine to some extent the treatment I provide them or how I need to alter the treatment plan. Some things specific to radiation that I need to think about, or have they had radiation treatment before? For example, if this patient had had prior breast radiation, I would need to take that into account. If they have a pacemaker or a defibrillator, I would need to know because these items do not tolerate radiation very well. Pregnancy is a contraindication essentially for radiation, so if a patient's a woman of childbearing age, I need to consider that. I need to consider prior chemotherapy because that could actually act to boost the impact and the side effects of the radiation. I need to take into account connective tissue disorders, which are just diseases of the soft tissue that could increase the risk of side effects to radiation. I also want to think a little bit about the family history and as if this might be a type of cancer that tends to run in families, which I would not expect for smoking-related lung cancer. I also need to think about their social history. Do they have family support? Do they have plans for children? And a big thing with radiation, as I mentioned, this woman is going to get 5 days a week of radiation for 6 weeks. Does she have transportation to come to that clinic this many times? Does she live too far away to get here, and do I need to find somewhere else that she needs to get her treatment? Do I need to help her quit smoking? So there are a lot of different factors outside of just the tumor and the cancer diagnosis that we need to think about at our initial consultation. We examine the patient, and in radiation oncology, this is typically more focused on the part of the body that we're going to be treating. For example, a brain tumor, we want to make sure that everywhere in the central nervous system is working, that their legs are both strong, their arms are strong, that their sense of taste is working. For a lung cancer patient, we want to listen to their heart and their lungs very well. If it's a bone metastasis, we want to do a really good exam to try to figure out which spot is causing pain. And I alluded to performance status earlier, and what that is what a patient is up and about doing every day. Because I know that a patient who is down here, I have 2 different scales here. One is a little bit more complicated, the Karnofsky performance test, but a patient, for example, who needs a hospital admission because of symptoms, they might not be very likely to tolerate my treatment well. The same as a patient who is in the bed more than half of the day. Whereas if I have a patient who's up and about doing their normal activities, I think that they have a very good chance to tolerate my treatment. So at the end, I always think about the patient's stage. I think about if they need surgery, if they need some form of systemic therapy, if they need radiation. And it's always important for us to remember that they might not need radiation. I certainly see patients in consult that I do not recommend radiation treatment. But for this patient, I mentioned 6 weeks of radiation treatment with chemotherapy. So she would need to go through with this CT scan, which is otherwise known as a simulation. This is what I tell my patients is not a plan to look for anything new or different from the PET scan she's already had, but to get a picture of her body in the radiation treatment position, because I'm going to be delivering 30 treatments, each of which is exactly the same. So she needs to be in the same position for each treatment. I need to think of which part of the body needs to be in the scan. So in this case, it would be her chest. Do I want to use contrast? And for lung, I will need to use what's called respiratory gating, so some method that I can track how the tumor moves as she breathes during treatment. So we do this setup, the patient is scanned, and we have lasers both on the CT scanner and the treatment room that are used to line up the patient. And the patient receives a mark or a tattoo to help line up for subsequent treatments. And here's just an image of what one of our CT simulators would look like, a normal CT scan. And this is an example of a body mold that might be used to position a patient. This would be more for a breast treatment. For a lung treatment, we would typically have both arms overhead so that we could use radiation beams coming in from all around the chest without treating through the arm. Next step would be treatment planning, which is a lot of work on a computer with many steps. It involves drawing targets, so drawing on the CT scan where the tumor is, drawing a radiation field, creating the plan and dose, and there are multiple quality assurance steps from checking the CT scan, checking the CT scan that tracks movement, checking all the drawings of the tumor that I have done, and then finally checking the radiation plan both before and after the doctor has reviewed the plan, including a test run on the treatment machine before the patient receives dose. And this quality assurance is really critical for the delivery of radiation. This whole process involves multiple people. The radiation oncologist is the physician. There are dosimetrists who make the radiation treatment plan. There are medical physicists who do most of the quality assurance checks. And of course, I mentioned the radiation therapists who are actually operating the treatment machine. This is a similar picture to the linear accelerator I showed earlier, but this patient, after the treatment plan was made, would come in. She would lie on the treatment table, shown here, in the exact same position as the CT scan done to plan the radiation in the same body mold that was made for her at that time. We would then use the treatment head to acquire a CT scan of her position on the table to make sure she's lined up appropriately. And if she's not lined up appropriately, we would shift the table to line up perfectly with the treatment plan. And then once the images align perfectly, we would deliver the treatment. I always tell the patients for this step that they're not going to feel anything when they get a radiation treatment. The radiation is X-rays. They're not going to feel hot or cold. They're not going to be radioactive when they leave. They're not going to glow. They're not going to be a danger to pregnant women or children. Because a lot of patients have a lot of anxiety coming in for the treatments, and really they find that after they receive their first one, they're not terribly exciting and are very well tolerated. The actual treatment time will tend to take about 10 to 15 minutes for each of the treatments. While I mentioned the individual treatment itself is typically well tolerated, there are some side effects of radiation treatment that can occur. One of these is fatigue. I would say that most of our patients who are coming into our clinic for multiple days of the week, for multiple weeks, are going to get tired. Some of that is just coming to the clinic so many times, and I think the actual radiation itself does have an impact. The other side effects of radiation really depend on where we're treating in the body. So in other words, where the radiation is pointed. So for this stage 3 lung cancer patient, what I would counsel them in my clinic would be this risk of esophagitis, which is irritation of your esophagus or swallowing tube. What this causes is sticking sensation of food when swallowing or some pain with swallowing, which I would anticipate starting around the midpoint of treatment, so about 3 weeks in, and then continuing until a couple of weeks after the treatment is done. This is what's known as an acute or short-term side effect that happens during treatment. Radiation can also have long-term side effects, which typically have to do with irritation or inflammation, scar tissue forming, or trouble with tissue healing. So in the lung situation, inflammation of the lung, the lining of the heart, or irritation of the actual blood vessels themselves, increasing the risk of heart disease, are the biggest possible side effects. And then every patient with cancer that's receiving radiation, I have to counsel them that while radiation is used to treat cancer, we also know that it can cause cancer. So the patients can be at the risk of a second different type of cancer within the radiation field, with that risk usually beginning about 10 years after the delivery of radiation. So I mentioned the radiation happens when being aimed, just to sort of revisit some of the other disease sites that I've alluded to, which would not be relevant for the patient case. If I'm treating a patient in the pelvis for, say, a cancer of the cervix, the prostate, or the rectum, the short-term side effects can be diarrhea or discomfort or burning with urination or dysuria. The long-term side effects could be scar tissue that can cause a bowel obstruction, ulceration within the bowel or the bladder, premature menopause, or erectile dysfunction. In the brain, similarly, during the short term during radiation, there can be nausea or headache. There can also be long-term issues with memory problems or radiation necrosis, which is a tissue injury because of the radiation. The common side effect from breast treatment would be skin irritation during the course of therapy, and there could subsequently be scar tissue formation, fibrosis of the breast, or injury to the brachial plexus, which is the nerve that controls the arm. And finally, head and neck radiation really can't avoid the glands that produce saliva, the spit glands, and also can't avoid the inside of the mouth. So you get a dry mouth, you get a lot of irritation inside the mouth. And so during the course of treatment, that can also cause loss of taste and weight loss. Also, the skin gets very irritated. And then in the long term after head and neck radiation, there can be a lot of scar tissue within the tissues of the neck, and the dry mouth can actually persist for many years after having radiation. All right, the next poll that I have here is about the side effects of radiation therapy. So A, radiation oncologists can concentrate on treating the tumor and ignore all of the patient's other medical problems. B, setting up a patient, scanning them, and marking them with a tattoo is always optional. C, preparing a treatment plan always includes multiple quality assurance steps. And D, the only side effect of radiation therapy is fatigue.
All right, and while we're waiting for those answers to come in, you mentioned this tattoo. How large do these tattoos tend to be?
These are tiny. I actually tend to pull up a small freckle on my arm to point to, so it's really like a dot of a ballpoint point pen.
Okay.
They are permanent. We do sometimes have some patients that really, really don't want a tattoo, and we'll use sort of a mark with a Sharpie and put tape over it.
Okay.
The problem is if a patient's going to get skin reaction in that sort of area, if the tape comes off, it can actually pull off some of the skin, and then also it's easy to accidentally wipe the marks off. So I do encourage the tattoos. They're very small.
Gotcha. Thank you.
Yeah, good question.
All right. So we have a lot of people saying C. How did they do?
I think that's a great answer. There's certainly a lot of quality assurance steps. We always have to make sure that everything is accurate in our treatment plans.
Great.
All right. So the last thing I wanted to go through in the last 10 minutes of this talk were some treatment planning examples, just to kind of show what a radiation treatment plan looks like and what I think about when I'm trying to create a radiation treatment plan on the computer for a patient. So the first example here is a lung case similar to the patient that I was describing of my case. So this is a CT scan of the chest of the patient. It's the simulation scan that's done in our department. And if you think about this, this is an image of the patient lying on their back. So this is their backbone here. Here's the table. And they're lying as if their head is back into the screen and their feet are coming out of the screen towards you. And so that means the left is on the right over here and the right is on the left. You can see the left in the R. So this patient has a tumor that's primarily on the right side. So say I'm designing a treatment plan for this patient. I'm going to draw the tumor. I'm going to draw the things that I'm worried about in the middle of the chest. So right here in the middle of the backbone is the spinal cord. I'm going to draw that because it's important to avoid dose. The esophagus is a little bit difficult to see in this plan, but it's somewhere in this area, so it's important that I draw that to try to avoid some radiation dose. And right on this slice, we're a little bit above the level of the heart, but these are the vessels that are sort of leading into the heart. So I want to think about the heart as I'm designing a radiation plan. And then finally, I want to think about the normal lung. So I would think about here this area that's in black on both sides. So this would be the right lung, and this would be the left lung. And it's important when treating a right-sided lung cancer, I really want to minimize the dose to the left lung because I know the right lung is going to get a significant dose. And these are similar images of the same thing, but this is an image if the patient is standing, looking at us from the screen, and this is an image from the side. So this is the kind of the best example of sparing the other lung, as well as the top and the bottom of the right lung. And then this color wash of things is the actual radiation dose. So this red, for example, I said I was treating to a dose of 60 gray. This might represent, say, a 50 gray, which is covering the tumor plus some margin. And then we have this dose fall off, where the green might be 40 gray and the blue might be a dose of about 20 gray. And so this kind of shows how we shape the dose and how we think about what the different organs at risk are, or the organs that we want to spare during the course of treatment. In planning a breast treatment, this is a sort of a cartoon of a patient lying there black getting a breast cancer treatment. So you can imagine the contralateral, the opposite breast would be underneath this graph here, and this is the breast that's receiving treatment. Whereas the lung would have been planned with many beams coming from different angles. Our breast radiation treatment can be planned with two different, what we call tangential fields. One radiation beam coming from this direction, and then one coming up the other direction. And we have several different types of beam we can select, and you can imagine if you're treating through a deep target, you would want to select a type of beam that's going to go deep into the tissue. So this is an example of a simpler to perform, or simpler to design type of radiation treatment. Similarly though, when doing a radiation treatment plan, again this is back to a CT image instead of a cartoon, we usually want to give a little bit of radiation dose just to the resection bed. This is where the lumpectomy or partial mastectomy was performed, and the surgeon left clips here. And again, this is a patient lying on their back, backbone is here on the couch, and these are the tops of the lung here. And so this would be the patient's right breast, and this is the resection cavity. And if we're giving extra dose and only treating a couple centimeters deep, we might want to select a radiation beam that doesn't go very deep, because that would spare dose to the lung here. So these are just a few different items we think about in terms of treatment planning. This is an example of a prostate. Again, a CT scan, but now instead of up in the lung, we're down at the level of the male pelvis. Again, the patient's head would be into the screen and feet toward us. And here you can think about you're wanting to spare, this is the femoral head, so the top of the leg bone. and here, we know that there can be a susceptibility or risk of fracture long term if we give too high of a dose. So you can see how some of this dose is curving around the top of the femur. The prostate is sitting right in front of the rectum and right in front of the bladder. And you can tell you have to have some overlap with these two adjacent organs. But again, we have more dose spreading to the sides here into the soft tissue rather than into the bladder or the rectum. This is another example of a breast treatment plan with the same beams as I had in the cartoon before, so one coming from up here and one coming from here. And you can see with this simple treatment plan, it's actually very nice at giving very little dose to the lung. If you remember the lung plan, that blue color that was some radiation dose was extending pretty far into the lung. But with this simple technique, we have less of what we call low dose spill. So while a part of the heart and a part of the lung are getting a high dose, most of it is getting very little dose at all. And this is just an example that I'm not going to go into with a graph of how we look at radiation doses and measure them and when we evaluate a treatment plan. We can also think a little bit about how we're going to position a patient to best design the radiation treatment. And breast is another example. This is a patient who's lying prone, so on their stomach. So in contrast, here we see the backbone on top, and the patient is lying on a table on a breastboard that allows the breast to go into a hole in the table. And you can see here that even though the heart, which is right here, has swung forward down onto the chest wall with gravity, there's actually no radiation dose to the heart and none to the lung at all with this radiation treatment plan. So this is a way we can use different accessories, different positioning to really tailor it. It would be the same radiation treatment, the same recommended treatment, but really tailor it to a patient and have the best possible dose distribution to treat the target, which is the breast, but then to spare the heart and the lung nearby. Another example is brain. There are a lot of structures in the head that we would want to spare with radiation. So an example for this one is we would draw the nerves going to the eyes. So we would have the eyes here. That would be something to avoid with radiation. This nerve going to the eye. And then further below, we're going to have the brain stem. So these are all things that we have to think about in the radiation treatment plan. And some of this is a sort of risk-benefit thing. If we know we can't afford for this tumor to grow back, we might have a radiation treatment plan that gives a little bit higher dose than we want to the optic nerve. And we might counsel the patient that there could be a risk of loss of vision. Although typically with brain treatments, we're able to keep this below a dose that the optic nerve would tolerate. So these are all just different considerations, and we have different sets of numbers that we use in making a treatment plan, which are beyond the scope of this lecture. But these are just some of the things that we think about in treating different disease sites. There are specialized techniques such as stereotactic radiosurgery or stereotactic body radiotherapy, which are a high dose per day with tight margins and a lot of image guidance. It's similar techniques, but it's just a little bit more specialized. But an example of this would be a lung tumor in the middle of the lung here. And you can see there's not as much of that low dose spill. There's not as much fall off. And here, instead of giving 2 gray a day, I'm likely giving 10 gray a day in only 5 treatments. And this is an example of a brain treatment that I would be treating with only 1 dose of radiation with the intent of eliminating this brain metastasis from a lung cancer. So this is all I had to talk about today. So I hope this was informative and able to give you a little bit of information about radiation, about kind of the thought process of a radiation oncologist and what a radiation oncologist does as they evaluate a cancer patient. I hope I've told you a little bit about the role of radiation, but also about how radiation surgery, chemotherapy, and other systemic therapies can really be used together. And we have to think about these. I clearly couldn't go over each different type of cancer and how we think about this, but I selected stage 3 lung as sort of a modality that treatment that radiation was the primary modality. I told you that radiation works by causing damage to DNA. It doesn't insta-kill the cells, but it allows them to eventually die off because they can't repair the damage. I've talked about a few of the different radiation techniques. Most of the treatments are these external treatments where the patients are lying on the table with a linear accelerator. There's also radiosurgery, which does not involve a knife. It's still external beam radiation treatments, but it's focused in. But also the brachytherapy, the implanted cedar catheter radiation, or radiation in the operating room. The radiation oncologist really works with a multidisciplinary team. That includes other physicians. We work to design radiation treatments, so we have to know a lot of anatomy. We have to manage the toxicities or the side effects during treatment. We also have a lot of important personnel within the radiation oncology department, and that includes radiation therapists who operate the machines, dosimetrists, which is extra training after radiation therapy training to actually create the radiation plan, radiation physicists, and of course nursing staff in our department. So I believe we'll have time for some questions to be written in, but that is all I wanted to talk about today.
All right, Dr. Weiner, thank you so much. This is a terrific amount of information. So it is an opportunity. There is an opportunity now for you to share your questions. B, we're going to assume that's not a question coming from we may have a couple of these that have filtered in late from an earlier poll. So I don't think everyone wanted to know about bees, but we'll give folks a minute and see if there are any questions that you may have. So please share those. Let's see. You mentioned the seeds for prostate cancer. So what kind of time frame are we? You mentioned those stay in permanently.
They do stay in permanently. So there are two different types of seeds, and what we think about is how long they last. The radiation lasts is called the half-life. So it's time that for the radiation source to get half of the activity. And so there are two different ones. One of them has a 60-day half-life roughly, and one has a 17-day half-life.
Okay.
But the type of radiation for these implanted radiation sources, we also have to think about the energy, which controls the distance that the radiation is. So the energy is very low for the prostate implant. So even though you're thinking it's lasting, only half of it's going to be gone in 17 days, a person would only really get radiation exposure if they were to sit on the man's lap. And so we always think time, distance, shielding. So even if someone sat on the patient's lap for an hour, that's still not that much time. So the patient's body shields some. You might limit your very close exposure, and then not, so those are the things you think about.
Gotcha. Okay, thank you. Can a patient receive radiation in the same area if they have a secondary cancer or a recurrence?
Yeah, that is a great question. So people ask that a lot. So typically it is challenging to do radiation in the same spot again. We definitely have to think about the cumulative radiation dose. The normal tissues can recover to some extent, but there's definitely a higher risk of toxicities. Time does play into effect. So say a patient has radiation many, many years ago and has a recurrence or new cancer in that spot, then it is possible that you could do some degree of radiation again. But if something recurs very, very quickly out of a first course of radiation, the risk of side effects is higher because the normal tissue doesn't have time to recover. And also you have to worry that if it didn't work the first time, it might not work the second time.
Gotcha. All right, thank you. And thanks to our audience member for that question. What is done to help minimize radiation treatment from damaging normal cells?
That is another great question. A lot of work has been done to look at this. There have been studies with medicines that are infused to try to prevent damage to normal cells, but we always worry one time that maybe we are going to impact the efficacy of the treatment by doing that. And also some of these treatments have had a lot of side effects, like very profound nausea, for example, from one of them. So sort of the risk benefit hasn't really been there. So what we do on a radiation therapy end, our radiation planning end, is we are very careful with our planning. So for example, on all those CT images, we would draw on there every single normal tissue that's close by, and we have a set of goals in mind to minimize that dose. It's clearly not going to be zero. For our stage 3 lung cancer patient, she's going to have a lymph node that's right next to the esophagus, so there's no way I can try to cure the cancer and eliminate dose, but we do the best we can in that regard with treatment planning.
All right, thank you. And let me try to frame maybe one last question before we wrap up. So it seems like, as with a lot of treating cancer patients and strategies to treat cancer patients, there's this balance between destroying the cancer without harming the patient. How much of that is simply following a standard of care and following the algorithms that are already researched and in place, and how much of that becomes more, I don't know, subjective or just involving a lot of judgment on a case-by-case basis?
So I think a lot of it is fairly standardized. For example, what I can do is I have a patient that I know I want to give 30 radiation treatments. I have a table, and for any organ in the body, there is a table of what dose all the organs can tolerate. However, with clinical expertise and kind of changing in patterns, sometimes we learn that, oh, this might be able to take a little bit more, maybe we should be careful. And another thing that a lot of our research is going into, we're trying to do what is called hypofractionated approaches, which is a higher dose a day for a shorter course. But we know that that's not quite as safe for the normal tissue. So we're trying to kind of figure out new constraints because we have to clearly be more conservative in that regard. So I think there is a lot that we know. Most of what we know is really based on kind of old studies where patients did have toxicities.
Right.
So there is, to some degree, some guesswork, but we're always working to improve that.
Okay, that seems like this is where a lot of the expertise and probably a lot of the more interesting aspects.
And some of it's different things, like even picking not necessarily the dose that we will allow, say, the esophagus or the normal lung to get. It's how much margin do you need to have on this tumor? Do you need to treat this as something that there's probably that microscopic disease that extends multiple centimeters, or is it something that you could really treat with a tight margin?
Right.
And so some of that is kind of, just things that we learn over time.
Gotcha. Thank you so much. Well, let's see. We've got a few things to do in wrapping up. We want to thank the generous support of the North Carolina General Assembly for their support of the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. We want to thank the Associate Director for the Outreach Program, Dr. Thomas Shea, Mary King, Veneranda Obore, and John Powell for all the hard work they do for this and each of our lectures. Again, I mentioned at the beginning of this, please take just a minute or two to take care of that lecture evaluation survey at unccn.org/eval. Upcoming community college lectures. October 16th, we have Caring for the Patient with Breast Cancer with Amy Depew, Betsy Blanton, Leah McDonnell, Emily Riddle, and Betsy Weehee, and then Caring for the Patient with Lung Cancer with Dr. Charlotte on February 19th. So we look forward to seeing you for both of those. Please spread the word. We have self-paced courses, including Caring for the Patient with Head and Neck Cancer and Caring for the Patient with GI Cancer, several others, so you can take these and, as I mentioned earlier, receive those certificates of participation. And we definitely encourage the community and college instructors out there to utilize all of the different courses. We've got a series of 12 now. This makes our 12th. So this completes our series that can be assigned to your students watched in class or assigned out of class. All right. Thank you all for participating. Again, please spread the word. unccn.org is our website. Lots of information there. Please don't hesitate to reach out to us with any questions, ideas, comments, etc. Thank you so much, Dr. Weiner. Thank you. Really appreciate having you here today.